طيب, Dr. DeFranzo, Dr. Abdelghani, and others, can we have 5 to 10 minutes discussion, questions? But we don't have. We don't, Dr. DeFranzo, Professor DeFranzo. So we don't have chairs, so we can ask you questions if you keep your place.
Whatever you want.
Okay. مين عنده أسئلة؟ أعطي له. بدي كمان ميكروفون. كمان ميكروفون. طيب. فيش غيره؟
سؤال للدكتور جهاد بروفيسور ديفرنزو. My question about the cardiovascular beneficial in group of SGL2 inhibitor. Are all the SGL2 inhibitor are the same? This is the first question. The second question, the increased incidence of the increased incidence of necrotizing fasciitis is associated with all subgroup of SGL2 inhibitors.
Yeah. So I guess the question is, all SGLT2 inhibitors the same? My personal opinion is, in fact, that they are. And as I said in my presentation, that the major differences or small differences in the outcomes are more related to the patient populations than the drugs themselves. I personally don't believe that canagliflozin has any significant SGLT1 inhibitory activity that makes it advantageous over the other two. So I would make my primary decision based on the cost of the medication.
The necrotizing fasciitis.
Dr. Jihad would. No? Okay. Other questions?
The increased incidence of necrotizing fasciitis in patients with SGL2 inhibitors.
I think you will answer by the floor, but in DECLARE there was no increase. In the opposite, there was reduction. There was really amazing. Maybe I would be happy just to, you can give us more data about that. In DECLARE there was reduction. There was no increase in this Fournier and this really phenomenon. Can you give us this?
Yeah, I actually think that this is a non-entity related to the SGLT2 inhibitors. There are something like 30 cases reported in 2.5 million individuals. That, if you were to calculate that and had a calculator, the incidence in the published data in all the SGLT trials is actually much less than the incidence that has been reported in a number of journals before the advent of the SGLT2 inhibitors. So I know it's a scary thing, but you need to remember that there is an incidence. It's about 1 in 500,000 diabetic patients treated with, who are not treated with SGLT2 inhibitors have this necrotizing fasciitis, and the incidence that's reported is even lower, and I think it's inappropriate to report a side effect that's less than the incidence in the disease when they're not being treated with the drug.
Okay, we have a question here, please.
The use of SGL2 inhibitors in underweight or slim patient. Did you recommend it? If not, what are the alternatives?
Yes,
Since
it's as
Professor
effective as in obese individuals. You mean type 1 or type 2? Type 2, you can, the only indication is what the renal function is. In terms, okay, tomorrow Dr. DeFranzo will speak about the treatment. But you have to remember, type 2 diabetes, SGLT2 have 2 different indications. One for glucose lowering. For that indication, the eGFR has to be above 60 or 45 in some treatments, some medications, and that's independent of the body weight. You have to remember that the FDA approved reduction of cardiovascular events in people with diabetes, and that is independent of glucose. And in incretins, we can see that the lower the eGFR, the greater the cardiovascular benefit, probably because the baseline benefit.
No, his question, can I repeat the question? He's asking, as long as we have indication to use SGL2 inhibitors for obese patients and cardiovascular patients.
Right.
What about patients with cardiovascular disease or non-cardiovascular disease that they have underweight? Do SGL2 will be benefit?
What do you mean underweight?
Because they are not obese.
Not
and
obese,
they are,
yeah, that's what I'm saying. BMI is not an indication, it's not considered.
I'd just like to say one thing, very simple. If you have a slim type 2 diabetic patient, measure GAD antibodies. You will have 40% possibilities that this patient is a LADA. Is a LADA. Is a latent autoimmune diabetes in adults. So you
this is a different
switch
story.
completely your mind, and you think that this is maybe a type 1.
So we have to take
so,
care.
okay,
We have to take in consideration those patients with underweight. They could have a
LADA.
GAD positive or they have a LADA. Okay.
What about a simple answer? There is no difference in the efficacy in lean versus obese type 2 diabetic patients. End.
No. He is aware of
lean
losing
people
weight.
lose less weight than obese people, and that's good. If you're lean, you don't have to lose weight. If you're obese, you lose weight. So in general, and this is very in general, the more overweight you are, the more likely you are to lose a little bit more weight. But in terms of glycemic control, A1C control, it doesn't make any difference whether you're lean or obese.
No, I'm going to ask you. Ribon, I think he's raising a question. Yes. And in my clinic, this patient is underweight, BMI 17, and he's going just to, we'd like to control his blood sugar. In practice, yes. What you can do, you can use it, but in practice, in my clinic, in your clinic, we do prefer to start insulin, maybe pioglitazone, because maybe these patients will not going to gain weight, maybe, or to reduce. So we have to think seriously, to think with these patients, but you can use it without any problem. Yeah. I think you get the point. Maybe in practice I will not use it, but you can use it.
The other thing you need to remember, half of the weight loss, or 40%, is water loss, it's not the fat loss. And that will bring cardiovascular benefit. So the weight loss in SGLT2 use is not always that bad, even if you are lean. Sometimes you can benefit from that. Just eat more. Eat more, eat more.
Okay, one more question. Okay.
Eat more.
My question related to complication. What factors more related to complication? Are they related to mentality of patient, their lifestyles, not committed to treat the different treatment, maybe social factors? I want these factors as a public health practitioner. Thank you.
Complications, what is the most important factor? I think he's asking, for you, what is the most important factors that can determine the side effects and the complications, the style life, medications, etc., etc. Okay? All these factors, because diabetes is not really a problem with just eating or lack of exercise or stress or etc., etc. It's something we have to look that all these factors will play a role, and to remember something which is very important, that hyperglycemia is one component of this problem. We have the same time dyslipidemia, heart failure, as was mentioned, dyslipidemia, hypertension, etc., history of MI, etc., etc. So we have to look all these factors together. Just to like to add it.
One more question, Dr. Tarazi.
Well, let's end really with this beautiful and fruitful session. Professor Di Fronzo, we are running off clinical inertia. Clinical inertia, metformin for 10 years, 7 years, hemoglobin A1C 10.5. As you said in your lecture, The SGL2 and the GLP should be the first line. Would you really change the guidelines and let's let the metformin be the second line and the SGL2, SGLP the first? Or you initiate early combination, SGL2 with metformin as the first line, and we continue with GLP whatsoever.
Yeah. So first, just clinical inertia is actually a huge problem, but I have to say I was shocked to see, as bad as we are in the United States, you finally beat us at something. It's incredible that you would wait 6 years to change the medication. In terms of treatment, and Mohammed and I think probably the same way. We believe there are 4 good drugs, okay? SGLT2 inhibitors, GLP-1 receptor agonist, pioglitazone, and metformin. Now, for me, I would definitely put metformin as number 4 on the list. And I think Mohammed and I agree that we would always institute therapy with at least 2, if not 3 drugs. And the 3 best ones, in my opinion, and probably Mohammed can speak for his mind, we would pick amongst GLP-1 receptor agonists, SGLT2 inhibitors, and pioglitazone. Cost is always going to be an issue. You're never going to be able to get around it. And
Professor.
Just a minute. We debated in diabetes care. Dr. Tarazi, if you go, I remember 2 years ago, that suggests to replace metformin with GLP-1 as first-line therapy. And we listed there all the advantages for doing that.
I have a question, Professor DeFronzo, Professor Abdelghani, and Dr. Jihad. You receive a patient for around 50 years old to your emergency room. They found the patient comes with chest pain. They found that he has ischemic heart disease. They put him for catheterization. The patient onset diabetes. According to guidelines, you start on metformin or SGL2.
So I actually deleted that slide. So let's say I'm here tonight. I'm not diagnosed to have, I don't have diabetes that I know of. And I start having chest pain. You take me to the hospital. I have a heart attack. Clear, ST elevations. Tomorrow my A1C comes back at 8.7. Please do not put me on metformin.
That's my question.
I want to live. So I want the GLP-1 receptor agonist and the SGLT2 inhibitor combined. And I already showed you the longer you wait to start the drugs, the more likely you are to have another MI. So metformin, in my opinion, is not an established anti-atherogenic agent. So give me the ones that will more likely allow me to survive the MI and live longer.
So allow me to say that the guidelines are tools, not rules. And so we should not start on metformin because this patient will not improve on metformin. He will not protect his cardiovascular stations. So SGL2 in combination or without metformin may be first-line therapy for these patients with cardiovascular disease. Absolutely. And this is the mistake we do in our clinic. We have a new patient with cardiovascular disease and we start on metformin. This is lose of time for those patients.
Yes, just one more thing. This is not a rare case. I showed you in patients who come to the ER who have no history of diabetes. If you check diabetes, 20% already have. So that's 20% of the patient who come with MI without history of diabetes.
So we have to start all.
So that's a very common scenario. That's a very common
this
situation.
is what we have in our clinic, that we receive a lot of those patients, and we should start on this class of medication in the sake of patients of his cardiovascular disease. Other questions? Do we have any question here? Dr. Tarazi, Dr. When Dr. Zidane كان في عنده question. Dr. Zidane, Dr. Muhammad had a question. ما هو لسه بيعملوا tuning. عندك لسه بيعملوا tuning. احنا we are waiting for the tuning.
Can I have a question? Our professor, regarding type 1 diabetes, really, please, we discussed, he left, no, he left? Yeah. I have to admit, regarding the use of SGL2 inhibitors in type 1 diabetes, I am really got confused. I get the message, it's good, but don't use it, or you can use it, but you be very careful when I can use it. The conclusion for me is too early, but despite fact, we do off-label to use it, we have very good results, etc., etc. So my question is, in practice, when you have to choose SGL2 inhibitors for patients with type 2, what is really the most important criteria to start SGL2 inhibitors in those patients? Type 1. Of course, type 1.
Now, first of all, I disagree on the fact that this is off-label. It's not off-label. They use the SGLT2, but it's been approved in June and is now available throughout Europe. In Europe, it's available. Off-label in the US, but in Europe is off-label. But then the same story happened with metformin. In Europe, metformin was for 15 years before it was approved in the US, so I'm not surprised. Okay, so this is the first point. So it's not off-label in Europe. You can buy and you can give to patients without signing any informed consent, providing the BMI is equal or above 27. Okay, so that's important to take into consideration. Regarding when to stop in patients with type 1 diabetes, definitely you stop when you have the patient that is not compliant with what you tell him or her to do. That's the problem. It's just not, the ketone bodies, of course, is the result of poor compliance, because you have to educate the patient, you have the physician to be involved and understanding how this patient could get into ketone bodies because it does not comply with what you tell to do. So in that case, you stop the use of SGLT2. But the patient may be reluctant because the blood glucose is getting very good. And so it is difficult after you have reduced considerably the amount of insulin and you have less hypoglycemia to stop this drug. So remember, you have to spend much time educating the patient. Reduction of hypoglycemia is consistent in this patient, really consistent. Even in adolescents. Professor Chiarelli treats off-label patients under the age of 18. It is definitely a major change in patients with type 1 diabetes that we are observing after 96 years. And I think we are very conservative as doctors in general, but definitely this is a major change.
I just add one thing. Within a year or two, you can use it even safely.
Recently, we are seeing some patients with uncontrolled diabetes type 2 who are on high doses of insulin. And we often try to add SGLT to those patients, let's say over 50 years or 60 years with 15 or more 15 or more diabetes duration. So what do you think about adding SGL2 inhibitors with metformin to patients with treated with insulin?
If they are using high dose of insulin,
yeah,
pioglitazone will be a better choice than SGLT2, but SGLT2 also definitely will be effective. Actually, tomorrow I have one case exactly about this situation, so
I'm advancing.
Yes, you are.
Yeah, but I know I also ask questions about clinical practice, but let's say those patients with Actus, which could be contraindicated because of heart failure or because of patients with edema. So we cannot use the Actus, and we know that pioglitazone is a very good medication.
SGLT2 and GLP-1.
SGL2
and GLP-1.
GLP-1. Okay. Better than using SGL2.
The both. You can use both.
Because the patient is already in 4 injections, so adding another GLP-1 is
okay. So in my mind, in modern days, there's no place for short-acting insulin in type 2 diabetes. So you can replace the short-acting insulin with GLP-1, keep him on the basal, and combine with the SGLT2.
This is my question.
Maybe the same questions. I know that Muhammad and Raf do like the combination of pioglitazone even in patients with insulin. But what we are facing in practice, the increase in body weight, this problem. So this is my question. You don't pay really concern that you will have increase in the body weight will make me a little bit be careful to go for that?
So I'm going to back up. Yeah. The greater the body weight, the greater the improvement in insulin sensitivity. The greater the body weight, the better the improvement in beta cell function. The greater the body weight, the greater the drop in LDL cholesterol. The greater the body weight gain, the greater the drop in triglycerides. The greater the body weight gain, the greater the increase in HDL. The greater the body weight gain, the greater the increase in endothelial dysfunction. Now, if you still don't have the message, go back to proactive. There's only one factor in proactive that said that you would live longer and not die. What is the one factor? Weight gain. So you have a choice. You can either be fat and live longer, or you can be lean and die. You take your choice.
Well, depends if you are man or woman.
Really, because I know Ralph he likes bioglitazone. I know that you are involved in pediatric population. Do you use really in practice bioglitazone in young and children? So I have your evidence. I do agree that SGL2 like it.
I want to take it. Yeah. So it's very, because I've been involved with the Today's study, okay? It is very clear from the Today's study that what pediatricians have done is a total disaster. Metformin does not work. Sulfonylureas don't work. And the only proven drug that works in adolescents, and remember, they have a lot worse heart failure, nephropathy, etc., comes from the data with the GLP-1 receptor agonist in liraglutide. So, a new paper on New England. Even a newer one. So I would say in this population that would be probably the drug that I would go with. And we actually have a big now multi-center trial. We're going to take the Today people who have failed and randomize, Mohammed and I are doing this, to GLP-1 alone with placebo, GLP-1 with pioglitazone, and GLP-1 with SGLT2 inhibitor. So the true answer to that question is not known. GLP-1 receptor agonists work. We're going to propose a study to the NIH to look at what should be the other drug added. So I would say it's not metformin, not for sure, but you can comment.
Yeah, there is the paper on New England is very clear. Now, the GLP-1 analogs works in children and adolescents with type 2 diabetes, definitely. And it should be the choice, the first choice. I agree that metformin is a disaster. I agree on that.
We still have tuning, so maybe you give us another question.
Should we sing a song?
I'll dance. Which lady wants to get up and dance with me?
Oh, you can choose. Maybe I would like to ask really Ralph regarding the latest guidelines. I know that you are not fan with the guidelines. Can you give us really your opinion? Do you perceive that we have to follow to apply these guidelines or just to forget it? Please, your opinion.
So I'm actually quite happy with the more revised guidelines. The only thing I just don't believe is that metformin should always be first-line drug. I personally believe the other three drugs are better, but more importantly, I think we should be using them in combination. But I think that they're a major advance to guidelines.
Thank you.
معليكي بس بدنا نكرم اوكي يعني هذا باولو احكي لك كلمتين نكسب وقت باولو بوزيلي So before finishing and going just to hear some music, just Her Highness and our chairman of the medical associations want to give a gratitude to Professor Paolo Pozzilli. Where is Paolo?
Signor Paolo Pozzilli. Grazie mille, le ringrazio per stare qui in Palestina. Grazie mille e benvenuta a Palestina. Questo è un...
Io. Io. Sì, اسمع نعمل وين حرم الله ايوه سي ايوه 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 سي ايوه.
الدكتور ماهر صغير.
تيست ايه واحد تيست ايوه.
تست هي تست
تيست ايه واحد ايوه. تيست ايه ايوه.
تمام. تست هي واحد. تست
A testing 1 2 1 test A.
واحد إيسا واحد إيسا